pre-recorded talks. So me and Dr. Ghosh are going to be introducing these speakers, all speakers in the beginning, followed by these 5 talks are going to play. And then these talks are going to be followed by a live Q&A session. So I will introduce the first 3 speakers, and Nilanjan is going to introduce the last 2. So our first speaker and kicking off this session is going to be Dr. Laurie Sehn. Dr. Sehn is a professor of medicine with British Columbia Cancer Center for lymphoid cancer. She is well known and clearly a leading authority in patients with lymphomas. She serves as the co-chair of the lymphoma site of the Canadian Cancer Trials Group and also co-chairs the Lunenburg Lymphoma Biomarker Consortium. Dr. Sehn will be talking about Pola-R-CHP, and he will be defending the role of this potential new regimen as the standard of care for diffuse large B-cell lymphoma. Debating Dr. Sehn is going to be Professor Ghosh, my worthy co-chair. So Dr. Ghosh is the chair of Hematological Oncology and Blood Disorders Program and chief of Lymphoma Division at the Levine Cancer Institute in Charlotte, North Carolina. He is well known for his translational and clinical work in patients with lymphoid disorders, excellent track record of drug development. And Dr. Ghosh is going to be debating that no, Pola-R-CHP is not the standard of care for all comers diffuse large B-cell lymphoma. Following these talks is going to be debate about whether dose-adjusted EPOCH is standard of care for patients with high-grade B-cell lymphoma with double hit molecular signature. So defending this regimen is going to be Professor Dunleavy. Dr. Kieron Dunleavy is the director of hematology and the leader of the lymphoid program at the Lombardi Comprehensive Cancer Institute in Washington, D.C. He's a professor of medicine at Georgetown University and clearly has done all the pioneer work in propagating dose-adjusted EPOCH in high-grade B-cell lymphomas. And I'm going to request Nilanjan to quickly introduce the last 2 speakers.
Thank you, Dr. Hamadani. So the next speaker who is actually going to oppose R-EPOCH in double hit lymphoma is Dr. Narendranath Epperla, who is an assistant professor in clinical medicine at the Ohio State University. He obtained a master's degree in clinical and translational science and completed his hematology and oncology fellowship where Dr. Hamadani is, that is in Medical College of Wisconsin. And he has authored numerous peer-reviewed publications and journals. So we're looking forward to him, talking about why R-EPOCH may not be the standard in double hit. And then following that will be Dr. Matthew Wilson, who is a consultant hematologist and honorary clinical senior lecturer at the Queen Elizabeth University Hospital in Glasgow, where he specializes in lymphoma and cellular therapy. And he will be talking about CNS prophylaxis. He has actually he has particular interest in prevention and management of secondary CNS lymphoma with number of publications and international presentations on this subject. He has also completed a diploma in lymphoid malignancies with the European School of Hematology. And he's done his fellowship in lymphoma at the Beatson West of Scotland Cancer Center. So we are looking forward to that as well. Thank you. We can get started.
Hi, I'm Laurie Sehn from BC Cancer in Vancouver. And today we're going to be exploring the question, is Pola-R-CHP the new standard of care for DLBCL? And I'd like to argue that it is. So these are my disclosures. So when we think about diffuse large B-cell lymphoma, this is really a very rewarding lymphoma that we treat in our own clinics all the time, being one of the most common non-Hodgkin lymphomas that we see. And it is rewarding because many patients can be cured with our current standard of care, which is R-CHOP. The real dilemma, however, for diffuse large B-cell lymphoma is that despite our success with R-CHOP, there continues to be a significant fraction of patients that prove to have treatment-resistant disease. So these patients either have primary progression or most of the time early relapsing disease, demonstrating a real chemotherapy inherent resistance. The other challenge with trying to make improvements in diffuse large B-cell lymphoma is the fact that because the majority of patients are cured with R-CHOP, any improvements that we try to make that's going to affect treatment for everybody has the risk of bringing in needless toxicity for those that don't actually need it. So it's been a fine balance. How do we make the outcomes better, particularly for those patients with treatment-resistant disease, while not inducing unnecessary toxicity for the majority of patients that will do just perfectly well with R-CHOP? What's the treatment algorithm in my own clinic? Right now, the only patients with diffuse large B-cell lymphoma I separate out are those patients with a dual rearrangement of MYC and BCL2, which we call the double hit lymphomas. Many of you probably realize that in the recent iteration of the WHO and the ICC classification, BCL6 has been pulled out of the mix, and that we're now defining double hit lymphoma as dual rearrangement of MYC and BCL2. In my own clinic, this does drive a different path of treatment. So we treat these patients more intensively as we think they do less well with R-CHOP. However, virtually everybody else gets treated with the recent standard of care, R-CHOP, which I'd like to argue is now going to be changing. So when we think about making progress in DLBCL, it's important to recognize that not all patients are the same. So it's been decades that we've recognized that there is biological heterogeneity in diffuse large B-cell lymphoma. Based on gene expression profiling, we were able to demonstrate that there are at least two subgroups of patients that we've called ABC and GCB subtype. And this is relevant because we know that these patients harbor different oncogenic mechanisms, and it's possible that novel agents will be preferentially beneficial in one or the other subtype. It's also relevant because it is prognostic in that the ABC subgroup has a significantly poorer outcome following R-CHOP. But we know that that's not the end to the biological heterogeneity. So using mutational profiling, there have been numerous elegant studies that have been able to highlight that even within ABC and GCB subgroups, there's significant genomic heterogeneity. We're now probably honing in on a novel classification scheme that will take these genomics into account. Currently, it's still not ready for prime time, so the most advanced classifier still omits to classify about 45% of the patients. And at this time, we don't have this information validated or a clinical tool that we can use in our own clinic. So despite our growing understanding of biology, we continue to treat all of our patients with diffuse large B-cell lymphoma the same. And when I say the same, we've been treating patients the same for a long time. So CHOP has been the backbone of chemotherapy for over 30 years now. And about 20 years ago, we made improvements on CHOP alone by adding rituximab to it. And that not only improved event-free survival, but also overall survival, and solidly established it as the standard of care moving forward. Once R-CHOP was established as the standard of care, we had numerous attempts to try and make it better. So we tried to make the chemotherapy component better by mixing up the drugs, bringing in more intensive therapy, shortening the interval of CHOP to 14 days, even stepping up to high-dose chemotherapy and stem cell transplant, and none of these approaches showed a definitive improvement on top of R-CHOP, I think firmly demonstrating that we've probably reached the limit of what we can do with chemotherapy. And those patients that have this inherent resistance really are going to require novel therapies that overcome this chemotherapy resistance. So that moved us into the era of novel therapy assessment. And we are seeing numerous novel therapies emerging that have the capacity to potentially overcome chemotherapy resistance in diffuse large B-cell lymphoma. The initial set of trials tested agents that were largely preferential for the ABC subgroup. So of all the novel therapy trials, the upfront randomized trials we had so far, there was the trial of obinutuzumab, the novel anti-CD20, which did not show benefit over rituximab. And then the remaining trials tested agents, including bortezomib, ibrutinib, and lenalidomide, that we understand to be preferentially beneficial in the non-GCB or ABC subgroup, hence requiring biomarker assessment and now patient selection for these trials. Ultimately, unfortunately, none of these trials were definitively positive and have not replaced R-CHOP to date. I'm just going to highlight a couple of the trials that really stem to show the difficulty that we've had trying to improve beyond R-CHOP, particularly when we try to introduce novel agents. So the Phoenix trial was a very important trial. This attempted to introduce the BTK inhibitor ibrutinib into the frontline setting because it was shown to be preferentially beneficial for ABC or non-GCB subgroup. This trial introduced biomarker assessment, trying to select out the non-GCB patients using immunohistochemistry and randomize selectively those patients to R-CHOP versus R-CHOP plus ibrutinib. And what we saw in the intention to treat analysis is that we did not see an improvement with ibrutinib R-CHOP compared with R-CHOP alone. But importantly, if you look on the left side of the curve, which is the intention to treat analysis, keep in mind this was a selected group of non-GCB subtype. And our expectation from historical data is that the baseline for this group should have been around at most the 50-50 mark, but we see that the baseline here with R-CHOP is up over 70%. So what was clear is that this introduction of the need for patient selection likely caused a lag in treatment such that some of our higher risk patients were not included in the trial. Hence, there was a selection bias toward higher risk patients, which would decrease the power of this study. However, this trial did show an intriguing benefit for the ibrutinib R-CHOP in patients who are younger than the age of 60. And looking at the older patients, it appeared that the added toxicity prohibited them from getting R-CHOP at full dose on time. But in younger patients who were able to tolerate the regimen, there was an intriguing signal of improved event-free survival and overall survival that will require further validation. But I think we learned important lessons from this trial about the difficulty in testing novel therapies up front. What about lenalidomide? So there's been a lot of enthusiasm that the addition of lenalidomide to R-CHOP may be beneficial. We had a phase 2 trial that suggested possible benefit. This was done in all comers, but when we had the more definitive phase 3 robust trial performed in patients with ABC subtype, we can see here that there was no benefit. Again, the very prolonged median time from diagnosis to treatment does suggest that we probably lost some of our higher risk patients along the way, possibly reducing the power of this study. So going beyond R-CHOP has been very difficult. So R-CHOP is proven a high bar to beat. Outcomes are fairly good with R-CHOP alone. So we need large patient numbers to prove that something is better. With some of the novel therapies, the requirement for introducing a biomarker has led to a lag in treatment initiation, and likely we're losing patients from participating in those studies from the highest risk categories. But also, what we've also learned is that there's biological heterogeneity that likely goes beyond ABC and GCB subtype, whereby we're probably not enriching our patients for the exact subgroup for the novel agent being introduced. So that takes us to the newest data, trying to introduce the novel agent polatuzumab vedotin into the frontline setting. So polatuzumab vedotin is an antibody drug conjugate targeting CD79B. It has an MMAE microtubule disruptor attached to it, so the toxic compound will disrupt microtubules. Once this agent targets CD79B, it gets absorbed into the cell, then the compound gets dissociated and causes apoptosis. Important to point out that CD79B is a universal target for DLBCL. So regardless of biology, it is present. So this is not an agent we would think to be preferentially beneficial in one subtype over another. So the Pola-R-CHP trial was designed really for all comers. This trial incorporated polatuzumab into the R-CHOP backbone, although because of the concern for overlapping toxicity with vincristine, vincristine was omitted. So essentially it served as a replacement for vincristine, and it was a head-to-head comparison of Pola-R-CHP versus R-CHOP. The polatuzumab was dosed as just one dose per cycle. Each cohort got up to 6 cycles of therapy, and then an additional 2 cycles of rituximab post-induction. This was a relatively comprehensive assessment as far as DLBCL patients go. So there were a few restrictions. So it included all patients this is intriguing. I think we must realize that this is not powered for definitive conclusions. We know that these subgroup analyses are not appropriately powered, but more importantly, they represent only a univariate look at these individual parameters. So, I think we can't overread what we're seeing here, and that there's likely that there are multifactorial elements at play, and we can't just look at one parameter and be certain whether or not there is preferential activity or not. Some of these parameters, like cell of origin, may be traveling with other high-risk features such as advanced stage, for example, or older age. With the follow-up that we have, the overall survival was not shown to be different, but of course, it's still a bit of an early time point for overall survival analysis, as we know patients can go on to get secondary therapies. And when we look at secondary therapies received by the cohorts, we can see that a much larger number of patients in the R-CHOP arm had to receive secondary therapy. So just over 30% of patients in R-CHOP went on to receive any secondary therapy, compared with only 22% in the Pola-R-CHP arm, including a higher rate of needing to go on to stem cell transplant and a higher rate of needing to go on to CAR T-cell therapy. Most importantly, though, as I said earlier, when we add something to the R-CHOP backbone, it becomes increasingly important to make sure that we're not adding added toxicity and eliminating our ability to give the key components that have proven curative in the past, or add toxicity that might outweigh the benefit being seen. And here, importantly, we see absolutely no difference in the toxicity between the two arms. So in the Pola-R-CHP arm, there was no difference in the capacity to give full dose chemotherapy on schedule. And importantly, when we look at individual toxicities, there was no significant difference between the two arms, including no significant difference in neuropathy. So this trial, of course, has raised some questions. Based on POLARIX, is Pola-R-CHP the new standard of care? I would argue that it is. So this is the first upfront trial that it's actually met its definitive primary endpoint of improved progression-free survival. And given that my goal in my patients is to cure as many patients as I can in the frontline setting, then, this trial tells us that we're going to be able to do that primarily with Pola-R-CHP more than R-CHOP, and with similar toxicity profile. Should it be used in all patients, regardless of IPI score or cell of origin? I think that, the data that I showed you on the subgroup analysis is definitely food for thought, but we need to explore that further and understand it better. And right now, I think using the intent to treat analysis is really most appropriate. What about for limited stage protocols where we're giving only 3 cycles of R-CHOP, for example, in a combined modality approach? I think this trial does not address whether or not we should change our chemotherapy there. Should Pola-R-CHOP be the comparator for all clinical trials moving forward? Well, routinely we have moved forward with our best regimen and then tried to go beyond that and use that as the comparator. So we can certainly argue that it should likely be the comparator moving forward in most clinical trials. What do we know about the current clinical trials underway? Well, some of them were actually started before the data from POLARIX emerged. So we will have trials that continue to use R-CHOP as a backbone, such as the trials that are testing the novel BTK inhibitors, the first-line trial that is testing tafasitamab lenalidomide. We also have bispecific antibody trials that are in the works, and we'll have to see how those are designed, but some of them will likely be designed comparing against R-CHOP. There are response adaptive trials in the works looking at using quantitative PET scanning or circulating tumor DNA and shifting gears based on early response assessment. And of course, we're going to see biology-driven trials that will likely include patients based on mutational analysis. But nonetheless, where do we stand right now? Well, clearly moving beyond R-CHOP has proven a challenge, but Pola-R-CHP from the Pola-R-CHP trial definitely proves that this regimen results in improved progression-free survival with similar toxicity. I think moving forward, there are next generation trials that will be emerging in the frontline setting that may add additional complexity. But until further data emerges, Pola-R-CHP does represent a new and important standard of care treatment for patients with DLBCL.
I'm Nilanjan Ghosh from the Levine Cancer Institute in Charlotte, North Carolina. I want to thank the organizers for inviting me to talk at the first World Congress of Controversies in Lymphoma. I've been tasked to oppose that Pola-R-CHP is the new standard of care in DLBCL. These are my disclosures. By now, you've heard the talk from Dr. Laurie Sehn, who spoke in favor of Pola-R-CHP in frontline DLBCL. I agree with Dr. Sehn, and this is a positive study, and it met its primary endpoint. But for the purpose of this presentation, I'll focus on a few limitations of the study and present some future directions. So why Pola-R-CHP may not be the new standard of care for all patients with newly diagnosed DLBCL? We'll look at the exclusion criteria for the Pola-R study and identify subgroups of patients who were excluded from participating in the study, but still had frontline DLBCL. We'll then look at the median time from diagnosis to treatment initiation and identify if that might have led to a selection bias on the study. We'll then look at a subgroup analysis of the progression-free survival, and then we'll talk about the lack of overall survival benefit with the current follow-up. And then we'll go on to cost-benefit analysis and finally end with future directions. So first, starting with the exclusion criteria, patients over the age of 80, those with IPI 0 to 1, ECOG performance score 3 or higher, those with positive Hep C, B, or HIV serology, with those with CNS involvement, and patients who had organ dysfunction, liver dysfunction, mild to moderate to severe liver dysfunction, and those with moderate to severe renal dysfunction were excluded from the study. So let's just look into a few of these subgroups and see what is out there. So the first one is age over 80. And there is a study, as we all know, with R-mini-CHOP, which was published more than a decade ago. And that's sort of our default standard for patients who are over the age of 80. The median age on that study was 83, with patients enrolled between 80 and 95 years old. Median PFS was 21 months, 2-year PFS was 47%, and median overall survival was 29 months. Due to the age group of patients on the study, we can understand that 22% of deaths on the study were unrelated to lymphoma or from the treatment of the lymphoma. So there's clearly room for improvement in this age group. Unfortunately, this age group was excluded in the study, but we'll talk down the road about future directions in this age group. Then looking at low-risk patients, like patients with low IPI, there was a recent publication, the FLYER study, which looked at 4 versus 6 cycles of R-CHOP in a randomized fashion in this low-risk population. And the 3-year EFS was 89%, and 3-year overall survival was 99% with 4 cycles of R-CHOP. And so that has become the default standard in this low-risk population, and the results are really excellent and has become a standard in this patient population. And I would say that this may be even hard to improve upon. Then we can look at patients with organ dysfunction. So as I indicated earlier, the patients with some hepatic and renal dysfunction shown on the slide were excluded from the study. At our institution, we did a retrospective analysis for patients who were excluded, and the inclusion criteria for the retrospective analysis was the exclusion criteria for for many frontline DLBCL studies. So when we look at these patients with hepatic and renal dysfunction, some of them had really high-grade hepatic and renal dysfunction, along with really poor performance status and very high-risk disease. They received treatment with either R-CHOP or R-EPOCH with dose modifications, typically in the anthracycline and in the vincristine components. But the outcomes, and we have seen these patients obviously in the real world, that the outcomes were fairly good. So these patients are often excluded from studies. Many of these patients are minorities, as you can see in our retrospective analysis. The 3-year PFS and OS was 80% in this patient population. So this kind of reminds us that we should not ever give up on patients with large cell lymphoma, even if they have organ dysfunction. And then a very important study, which was published in JCO not too long ago, this looked at a diagnosis to treatment interval, also known as DTI, at 2 large databases, the MER database and the LYSA database. And what they found is that longer DTI was associated with improved event-free survival at 24 months, and that the association with EFS at 24 months remains significant after adjustment for the IPI. So this is an independent prognostic factor. And what you can see from these curves is that patients who could wait long to get treatment, like in the blue curve or in the yellow curve, up to 4, 5, 6 weeks, those patients really did much better than the patients who needed to be treated earlier. And that just meant that, that's selected for a higher risk population. So when we look at the Pola-R-CHP study, the median DTI was balanced between the arms, which is great. So this is not a criticism for biasing one group versus the other, but overall, the median DTI was 26 days. And we can see from the curves over here that those patients, if you look at what was below the yellow line, those patients who had a shorter DTI, their outcomes were worse. So this high-risk population probably didn't get represented well on the Pola-R-CHP study. And that's sort of a criticism for many clinical trials. There are some studies which will allow for 1 cycle of R-CHOP so that patients can be quickly enrolled. And then from second cycle, they start the investigational agents to allow for the high-risk patients who need to be treated urgently to go on the study. But that did not happen in the Pola-R-CHP study. Then looking at the progression-free survival, clearly, this met its pre-specified endpoint and a statistically significant difference in progression-free survival, as is shown over here, a 6.5% improvement in PFS favoring Pola-R-CHP with a median follow-up of 28.2 months, and that translates roughly to benefiting, to derive benefit, you treat about 16 patients for 1 patient to benefit. So that leads us to look at the subgroups of patients, and subgroup analysis always should be interpreted with a grain of salt. But here, when we look at the subgroups which had no clear benefit based on this forest plot, we see that age less than equal to 60, female patients, IPI 2, as you can see over here, this is IPI 2 right here. Then the patients who had bulky disease present, and those patients with GCB subtype, as well as those patients with double or triple hit lymphoma. So, those are the groups which did not seem to have a clear benefit with Pola-R-CHP. And, the next part of it is that there is currently no overall survival benefit. So I know the follow-up is relatively short, and part of this could be because of the magnitude of difference in PFS is not very high, although it is statistically significant, and also that salvage therapies like CAR T-cell therapy and other potentially curative therapies in the second line and third line setting can make it, can allow for prevention of what we would otherwise see an overall survival benefit in a frontline DLBCL study. We would need longer follow-up to see how this pans out, but with the current follow-up, we don't have an overall survival benefit. Finally, let's look at the cost-benefit analysis. So this was a study which was published recently in Blood, and what the authors, they looked at the cost-benefit between Pola-R-CHP and R-CHOP, and assuming that a 5-year PFS of 69.6% with Pola-R-CHP and 62.7% with R-CHOP, Pola-R-CHP was cost-effective at a willingness to pay of $150,000 per quality adjusted life year. So in order to come to this conclusion, they use Markov models, and they also made several assumptions. The first assumption was that the 5-year PFS with Pola-R-CHP won't fall below 66.1%, otherwise the benefit goes away. A second one was over time, there'll be a overall survival benefit with Pola-R-CHP over R-CHOP. The third was that availability and widespread use of CAR T cell therapy in the second line setting. So again, that is, while it's approved in the United States, we have to see how the uptake is going to be and how easy will it be for patients to get second line CAR T without other treatments in between, because it does take some time to set up CAR T cell therapy, and some of the diseases are very aggressive that patients may not be able to wait that long to get CAR T cell therapy. And then in the second line setting. And the last was that CAR T costs will remain high. So currently we know that the CAR T costs are very high, but the authors assume that these costs will remain very high, and therefore if you're able to cure more patients in the frontline setting, you would avoid those costs in the second line, and that would give an advantage to Pola-R-CHP over R-CHOP, because less patients would need to be salvaged in the second line with a very expensive second line therapy. So I'm not a health economist, but I'll just quote what was there in the paper for simplicity. And what the authors mentioned was that if Pola-R-CHP is adopted as frontline therapy for all DLBCL patients in the United States, this will lead to an increase of $1.8 billion in healthcare expenditures. This highlights that interventions to potentially decrease the cost of Pola-R-CHP or identify subpopulations that derive the highest benefit would improve its budget impact. So again, that goes back to subgroup analysis as well, and trying to identify populations which may not have benefited enough. So now let's move on to the future, right? So yes, we have a positive study, and it did show an improvement over our standard of R-CHOP. So but how can we build on this? And what other new agents can we incorporate on the platform? So we did a study recently with bispecific antibody glofitamab, CD20 CD3 bispecific antibody combination with R-CHOP in both relapse refractory and frontline DLBCL. This was presented at ASH last year, and I'm only showing you the results for the frontline cohort. And this is a very early readout, more to come in next future meetings. But the overall response rate with this combination was presented was 100% with a complete response rate of 89%. Cytokine release syndrome was really low in the frontline setting at 3.8%, and that was only grade 1. And there was no incidence of ICANS or neurotoxicity. In terms of future direction, ongoing studies are now looking at glofitamab plus Pola-R-CHP. Another study is looking at epcoritamab plus R-CHOP, and I'm sure there are other studies incorporating bispecific antibodies, but I'm only highlighting 2 on this slide. Now, going back to elderly DLBCL, I showed you that 80 and above were not enrolled on the POLARIX study. And the current standard with R-mini-CHOP, I presented the data in a previous slide. So to build on that, there's a study called Polar-Bear. I love the name. It's Pola-R-mini-CHP versus R-mini-CHOP for patients of 80 or above, or 75 and frail, according to Simplified Comprehensive Geriatric Assessment. Then there's a SWOG study looking at oral azacitidine for elderly patients, with R-mini-CHOP. And then there is studies even looking at bispecific antibodies such as mosunetuzumab monotherapy in elderly unfit DLBCL. Finally, future directions incorporating novel agents based on molecular and immune signatures. This is a slide provided to me by kindly by Dr. Brad Call from Washington University. This is an ECOG-led study looking at different molecular immune subtypes and adding things like PI3 kinase delta inhibitors, bispecific antibodies, EZH2 inhibitors, JAK2 inhibitors, and ibrutinib, or sorry, zanubrutinib, which is the BTK inhibitor, to Pola-R-CHP, to sort of build on and really identify subtypes which can perhaps benefit. And if safety and efficacy is noted, then these can be individual randomized studies. And on this study, since it takes time to get the molecular subtyping, first cycle of treatment, either with Pola-R-CHP or R-CHOP, would be allowed. So to conclude, where can we not apply the POLARx data? So we are not able to apply the POLARx data to patients who are not represented on the study, like patients with secondary CNS involvement, patients over age of 80, IPI 0 to 1, patients who need immediate treatment due to impending or existing organ dysfunction. And which patients are not likely to benefit from Pola-R-CHP? Those patients with age less than 60, IPI 2, GCB subtype, double hit or triple hit lymphoma, and patients with bulky disease. Thank you very much for your attention.
Hello, my name is Kieron Dunleavy from Georgetown University. I would like to thank the organizers of the CO.LYM conference for inviting me here today. The title of my talk is a question. The question is does suggested EPOCH R the standard of care for double hit lymphomas? And I would say yes, and I will explain why over the next 15 minutes. Shown here are my disclosures. So the outcome for patients with diffuse large B-cell lymphoma in the modern era is shown here. In this study, following immunochemotherapy and a median follow-up time of 5 years, the event-free survival for both arms was approximately 80%. And we've done a very good job of identifying clinical characteristics that predict outcome in diffuse large B-cell lymphoma. As shown in the Kaplan-Meier curve here on the left, with low risk or low IPI patients having an excellent outcome and high IPI patients having an inferior outcome. The role of cell of origin is somewhat controversial, but many studies have shown that the activated B-cell subtype of diffuse large B-cell lymphoma is associated with a worse outcome. And a few years ago, it was shown that patients who had tumors with a MYC and a BCL2 translocation, so-called double hit lymphoma, had an inferior outcome compared to those who had de novo diffuse large B-cell lymphoma. And this is shown here in the second Kaplan-Meier curve. You can see that the OS and PFS of patients with double hit lymphoma is in the range of 30 to 40% compared to 80% for people with DLBCL and OS. And subsequent to this second study, many other studies have shown an inferior outcome for patients with double hit lymphoma and with a MYC rearrangement. So what is double hit lymphoma? Well, approximately 30% of diffuse large B-cell lymphomas have got a BCL2 rearrangement. Approximately 10% have got a MYC rearrangement. These double hit lymphomas have got a MYC and a BCL2 rearrangement, and this constitutes about 4 or 5% of all aggressive B-cell lymphomas. These are almost always of GCB origin. Sometimes these tumors have a BCL6 rearrangement. These are often of ABC origin. And if you have a tumor with a BCL2, a MYC, and a BCL6 rearrangement, this is called a triple hit lymphoma. It's important to distinguish this from double expressor lymphomas. A very high proportion of diffuse large B-cell lymphoma cases have got high MYC and high BCL2 expression, but without the rearrangements. And these, in contrast to double hit lymphomas, are usually of ABC origin. So this is where we are in terms of our understanding of the spectrum of aggressive B-cell lymphomas. We have diffuse large B-cell lymphoma, NOS on one end of this, and Burkitt lymphoma on the other end. And these high-grade B-cell lymphoma entities are shown here. Most high-grade B-cell lymphomas have a MYC and BCL2 and or BCL6 rearrangement, but there is an entity included in the WHO classification called high-grade B-cell lymphoma NOS, and these do not have a MYC and a BCL2 translocation. And the double hit story continues to evolve and is complicated, as shown by these two studies here. The first of these studies, shown on the left, is a study that was done by David Scott's group in British Columbia. They looked at over 150 cases of GCB, diffuse large B-cell lymphoma. They performed RNA sequencing, identified a 104 gene signature called a double hit signature. And what was interesting here was that when they looked at the cases with the double hit signature, a proportion of those had a MYC and a BCL2 translocation by FISH, but a significant amount of them did not. And they had an inferior outcome following R-CHOP treatment. Similarly, a UK group applied a gene expression classifier to over 900 cases from clinical trials. They identified a molecular high-grade signature. And again, while a proportion of these cases had a MYC and a BCL2 translocation, a significant number of them did not, but they had an inferior outcome following R-CHOP treatment. So these two studies are very important in really identifying that there are double hit biology tumors that are not captured by FISH when we look for MYC and BCL2 translocations. And in terms of where do these double hit or high-grade B-cell lymphoma cases fit in the updated genetic classifications of diffuse large B-cell lymphoma, shown here are two recent updates on the B-cell lymphoma. Shown here are two recent updates on the molecular classification of DLBCL from the did not have a worse outcome, as shown here with PFS and OS. There have been two prospective studies in MYC rearranged aggressive B-cell lymphoma. The first of these used dose-adjusted EPOCH-R in 53 patients, and the 4-year EFS and OS were 71% and 77%. The second study looked at adding is very effective in aggressive B-cell lymphoma. We previously did a study in 30 patients with Burkitt lymphoma and showed an excellent freedom from progression and overall survival. That led to a multi-center study of the regimen in Burkitt lymphoma in 113 patients. And the EFS and OS shown here were over 80%. So the regimen works very well in Burkitt lymphoma, which is highly aggressive and highly proliferative. For these reasons, the and the overall survival from that study. And it's interesting that patients with a double hit had a slightly better outcome compared to patients with single hit. And in this study of 53 patients, approximately half of the patients were double hit and half of the patients. It may be a result of the decreased immune microenvironment signature, which has been described in high-grade cases, which may be different from DLBCL, NOS, but there are also a lot of other reasons why CAR T cells and other novel approaches may be helpful here. When we discuss treatment of high-grade B-cell lymphoma, the question of CNS prophylaxis always comes up. This is controversial in diffuse large B-cell lymphoma. In B-cell lymphoma, especially from retrospective studies, we know that there is a very high risk of CNS dissemination and CNS relapse. I think in these cases, it's important to have a very low threshold to check the CNS, to perform cytology and flow cytometry. While the role of CNS prophylaxis is unclear because we have not been able to do the optimal studies to inform us on the answer to this question, I would say that given the high risk of CNS dissemination, it's very reasonable to strongly consider institution of some kind of CNS prophylaxis for these cases. So in conclusion, double-hit lymphomas, high-grade B-cell lymphomas remain a therapeutic challenge. There's no doubt that the outcome for this subset of diseases is poor compared to DLBCL NOS following standard approaches. Controversy as to the optimal frontline approach persists. I would say that retrospective experiences and limited because of the rarity of these tumors, prospective data favor dose-intensive approaches. So coming back to the question that I was asked regarding the use of dose-adjusted EPOCH in double-hit lymphoma, I would say that it is highly effective in Burkitt lymphoma. This has now been shown in a multi-center trial and also in a randomized trial done by the Hoven group. In early results, there was equivalent efficacy of dose-adjusted EPOCH compared to R-Codex-M IVAC, but a lot less toxicity with dose-adjusted EPOCH. So I would conclude that based on available data, it is a reasonable frontline approach. I do think that other standard Burkitt lymphoma regimens are effective in double-hit lymphomas and high-grade B-cell lymphomas, but the challenge here is that those are not well tolerated by older people, and most people with a new diagnosis of double-hit high-grade B-cell lymphoma are in their 60s and 70s and not able to tolerate highly intensive approaches. There are a number of novel strategies and new agents in development for relapsed and refractory high-grade B-cell lymphoma. And as I've talked about, there is very promising data, particularly with anti-CD19 CAR T cells. So it's going to be really interesting to study these new approaches in the upfront setting in subsets such as high-grade B-cell lymphoma and assess if they have a role in upfront therapy ultimately. With that, I would like to thank you for your attention, and I look forward to the discussion.
Hello, everyone. I am Narendranath Epperla from Ohio State University, and today I will be presenting on is R dose-adjusted EPOCH the standard of care for double-hit lymphomas, and I would be arguing no, or at least will make an attempt to say that there are better options than dose-adjusted R-EPOCH for double-hit lymphomas. A very quick primer. I don't need to educate the audience here, but patients who have chromosomal translocations involving MYC, BCL2, and or BCL6 genes are defined as double-hit lymphoma patients. If they have the chromosomal translocations involving all the three genes, then it's called as triple-hit lymphoma. 5 to 10% of all diffuse large B-cell lymphomas are double-hit lymphomas, and only 1% of all diffuse large B-cell lymphomas are triple-hit lymphomas. As shown on the cartoon here, most of the double-hit lymphomas are GCB subtype, almost 60 to 80% of them, and they are MYC and BCL2 gene rearranged. 10 to 18% of the double-hit lymphomas may be ABC subtype, and they're usually on the minority, 10 to 18%, and they usually entail MYC and BCL6 rearrangement. This is a slide that is showing the older and the newer WHO classification. As we all know, back in 2016, in the new WHO classification, the double hit and triple hit lymphomas were categorized or replaced with high-grade B-cell lymphoma with MYC and BCL2 and or BCL6 rearrangements. And the most recent iteration shown on the right side, it is now recategorized as DLBCL or high-grade B-cell lymphoma with MYC and BCL2 rearrangement. Please note that the triple hit lymphomas are now categorized under rare B-cell lymphomas. For the purpose of the talk, I will be referring to both double hit and triple hit lymphomas. Okay, I want to highlight a few salient features and caveats associated with double hit lymphomas. Double hit lymphomas are characterized by refractoriness to the standard chemotherapy. They have more extranodal involvement compared to non-double hit lymphomas. There is no accepted standard approach to initial treatment of double hit lymphomas. And one thing is definitely accepted by everyone, that the outcomes are inferior when treated with R-CHOP in these patients, with an overall survival ranging anywhere between 5 to 24 months across various studies. Yes, dose-adjusted R-EPOCH is commonly used, but let's see if there is any data that shows superior outcomes beyond R-EPOCH. Couple more caveats. Patients achieving a complete remission, especially CR1 with two frontline therapy in double hit lymphomas, are associated with good outcomes. I'm showing two studies here on this slide. The study on the left-hand side is a prospective multi-center phase 2 study by Hovan Group, clearly showed that the patients who achieved a CR had superior overall survival. So just to orient you all, that there was a landmark analysis done in this study at 7 months, and those who achieved a CR, as you can see here, almost had a plateau compared to those who did not achieve a CR. And this is, remember, all double hit lymphoma patients. And we'll talk about this study in a little bit more detail in the subsequent slides. On the right-hand side is a multi-center retrospective study led by Dr. Landsberg and his group. This included a total of 159 patients and included patients across 19 US academic centers. What I'm trying to show you here is patients, again, in this slide, patients achieving a complete remission had a 3-year relapse-free survival of 80% and 3-year overall survival of 87%. In this Hovan study, the regimen was R-CHOP with lenalidomide or R-squared CHOP. In this study by Dr. Landsberg, the induction regimen for a double hit lymphoma patients was according to at the discretion of the treating physician. So there were few patients who had received R-CHOP and there were few who received R-EPOCH. But the point to take on this slide on this study is that achieving the CR to the frontline therapy in double hit lymphomas is associated with good outcomes. On the contrary, patients who relapse, especially double hit lymphoma patients, the outcomes are very poor. In this study by Dr. Herrera and his colleagues, you can clearly see the 4-year progression-free survival was 28%. Again, these are all the relapsed double hit lymphoma patients who received autologous stem cell transplantation, despite which the 4-year PFS was 28% relative to 57%. Sorry, this should be PFS relative to 57% 4-year PFS for patients who were non-double hit, and the 4-year overall survival was 25% in those who were double hit relative to 4-year overall survival of 66%. Again, trying to make a point here that we have one shot, that is at the start of the induction treatment, and we need to make that count. Okay, do we have any head-to-head data comparing R-CHOP to dose-adjusted R-EPOCH for double-hit lymphoma patients? In this phase 3 randomized study that included 524 patients, comparing dose-adjusted R-EPOCH to R-CHOP, that was the alliance of CALGB 50303, there is no difference in the progression-free survival or overall survival noted between the two groups. However, among the 249 patients with available CMYC data, which is essentially 50% of the enrolled patient had CMYC data, only 13 were positive for rearrangements, 6 in the R-CHOP arm and 7 in the dose-adjusted EPOCH arm. And of these 13 CMYC rearranged cases, only 3 were double-hit lymphomas. So that's a small, extremely small sample size of double-hit lymphoma patients in this study makes it impossible to compare these two regimens for this particular high-risk subgroup of DLBCLs. Do we have any real-world analysis? In the recently presented data at EHA, the investigators included patients with advanced stage double hit or triple hit treated with either R-CHOP or R-EPOCH using Flatiron electronic health record between Jan 2011 to June 2020. They included a total of 154 double hit or triple hit cases, of whom 43 received R-CHOP chemotherapy and 111 received R-EPOCH chemotherapy. The median age is as shown in the parentheses there. You can see here in the Kaplan-Meier curve, the 4-year survival in the patients who received R-CHOP. Again, these are all double-hit lymphoma patients who received R-CHOP was 54.5%, and the 4-year overall survival in those receiving R-EPOCH was close to 50%, which was and the survival was not statistically significant. However, the most important limitation of the study is the retrospective study design, and the treatment was at the discretion of the treating physician, and it's unclear as to why some of the physicians chose R-CHOP for treating double-hit lymphomas versus some others choosing R-EPOCH. Thereby, between the prospective study and the retrospective study, I don't think we have a clear-cut answer in this subgroup of DLBCL patients, that is the double-hit lymphoma patients, as to which is superior. But definitely we do know, based on the available data, that patients who receive R-CHOP have inferior outcomes. Okay, let's go beyond dose-adjusted R-EPOCH. First of the few studies is the R-squared-CHOP, wherein the lenalidomide is combined with R-CHOP. Now, we all know lenalidomide is an oral immunomodulatory drug that has both direct anti-tumor effects and indirect effects on the tumor microenvironment. It downregulates MYC and its target genes via affecting the cerebron and IRF4 genes in the lymphoid cells, thereby making it as an attractive option for studying in patients with MYC-positive large B-cell lymphomas. In this multi-center prospective phase 2 study, there were a total of 82 patients enrolled, of which 53 patients were either double hit or triple hit. The rest were CMYC rearranged or single hit patients. Lenalidomide was administered at a dose of 15 milligrams days 1 to 14 and was combined with standard dose R-CHOP. You can see here the 2-year overall survival for all the patients was 73%, and the 2-year event-free survival for all the patients was 63%. I just wanted to give you a snapshot of how does this compare or fare with the data from the dose-adjusted R-EPOCH. Again, I want to emphasize we should not be doing cross-trial comparisons. However, I just wanted to give a snapshot so we know exactly how this data compares to the existing data with R-EPOCH. The sample size was 53 and in the phase 2 study with R-EPOCH compared to 82 in the R-squared-CHOP. 24 patients were double or triple hit in the R-EPOCH study, and there were 53 patients with double or triple hit in the R-squared-CHOP study. Median age was comparable. A decent number of patients were high IPI score. 74% of the patients achieved a complete response by PET on end of treatment imaging in R-EPOCH study compared to 67% in the R-squared-CHOP. The overall survival rate and the EFS rate were pretty comparable between the two studies. Now, here's an important caveat. This is all comers, not just the double hit lymphoma patients. Important point to note, grade 3 or higher infection was noted in 24% of cycles in patients receiving dose-adjusted R-EPOCH compared to 2.8% of cycles in those receiving R-squared-CHOP with no grade 4 infections. There were 3 treatment-related deaths in those receiving a dose-adjusted R-EPOCH, and there were none in those receiving R-squared-CHOP. Let's go to the next study, which is combining lenalidomide with dose-adjusted EPOCH-R. This is a phase 1 study that included 15 patients, and 5 of them were double-hit lymphoma patients. The combination was deemed to be feasible, and the len dosing of 15 milligrams was the maximum tolerated dose for this combinatorial approach. Not unsurprisingly, the major toxicity was hematological, with grade 3 or higher neutropenia rate being 93%, grade 3 or higher anemia of 67%, and thrombocytopenia of 40%. Grade 3 non-hematological adverse events included hypokalemia and thromboembolism. Again, this was mainly done to evaluate safety, but the preliminary efficacy noted in the study was a CR rate of 87% with a 2-year overall survival and progression-free survival of 87%. A phase 2 study is ongoing and we'll await the results in the future if this regimen is indeed superior to dose-adjusted R-EPOCH. Let's go to the next study, which is venetoclax in combination with dose-adjusted R-EPOCH. This is another phase 1 study wherein there were a total of 30 patients that were enrolled, of which 15 patients were double-hit or triple-hit lymphoma patients. The maximum tolerated dose was 800 milligrams for 10 days. However, the established phase 2 dose was 600 milligrams for 5 days due to tolerability for treatment duration. Again, not unsurprisingly, the most common grade 3 or higher adverse events were cytopenias, noted in 93% of patients, with febrile neutropenia of 63%. Grade 3 or higher non-hematological adverse events included hypophosphatemia, hypokalemia, and hyperglycemia. CDS adverse events included infection that was noted in 23% of patients and GI toxicity that was noted in 27% of patients. And there was 1 treatment-related death. The combination is now currently being investigated in Alliance 051701. This is a snapshot of the preliminary efficacy noted in this study. You can see here the 2-year overall survival for all comers on this study was close to 90%, and the 2-year event-free survival was 83%. When you just look at the double-hit lymphoma patients, the CR rate was 87%, and the estimated 2-year event-free survival and overall survivals were 65% and 79% respectively. Going on to the next study, which is CAR T cell therapy or ZUMA-12. So just wanted to first orient to this study schema. This study included patients with high risk diffuse large B-cell lymphoma. How did they define high risk? Patients who had IPI score of 3 or higher, or patients who were double or triple hit lymphoma with PET positivity after 2 cycles of chemotherapy. All these patients should have had this anthracycline based, depending upon their underlying histology. So for example, if the patients were double hit or triple hit, they could have received dose-adjusted R-DA-EPOCH, and if they were high IPI without double or triple hit, they could have received R-CHOP. But the most important thing is these were high IPI scores, double or triple hit with PET positivity after 2 cycles of anthracycline-based chemotherapy. These patients received fludarabine and Cytoxan, the standard lymphodepleting platform, followed by a single infusion of axicabagene ciloleucel, administered at a target dose of 2 times 10 to the power of 6 anti-CD19 CAR T cells. The median age in this study was 61 years, predominantly males. And most importantly, 40% of the patients enrolled in the study were double or triple hit lymphoma. The overall response rate was 89%, with a complete response rate of 78%. Again, just to compare this to the ZUMA-1, which was patients receiving axi-cel in third or beyond lines, third line or beyond. The median time to first objective response was 29 days. This is a subgroup analysis. Again, just wanted to emphasize that the small sample size makes it really hard to power the analysis. However, it does provide some important signals. You look at the double or triple hit patients, the overall response rates, whether you define double or triple hit based on the central laboratory or local laboratory, the overall response rates were the 90% or higher. At a median follow-up duration of 16 months, the median duration of response, event-free survival, progression-free survival, and overall survival were not reached. When you look at the 12-month duration of response, it was close to 81%. You look at 12-month event-free survival, it was 72.5%. 12-month estimated PFS rate was close to 75%, and then 12-month overall survival rate was close to 91%. How about toxicity? All the patients experienced any grade cytokine release syndrome, but only 3 patients experienced grade 3 or higher CRS. That was predominated by fever, seen in 4 patients, and hypoxia seen in 5 patients. Any grade neurological events were noted in 73% of the patients enrolled, or 29 patients, of which 9 patients had grade 3 or higher, with 2 patients experiencing grade 3 or higher confusion state, and 6 patients experiencing grade 3 or higher encephalopathy. So I think CAR-T has shown promising data, and what I want to emphasize is, yes, dose-adjusted R-DA-EPOCH has shown a very good activity. However, one cannot use this regimen for all patients with double or triple hit, and we need to come up with unique ways to treat these patients. On the other hand, we just can't keep stacking up novel agents on top of R-DA-EPOCH, because it is important to weigh the risks and benefits, because at the end of the day, yes, we need to improve the efficacy of these patients, but also we need to be very, very careful in balancing out the toxicity or minimizing the toxicity. And I would like to summarize the talk by saying the double hit or triple hit lymphomas are very high risk subtypes. achieving high CR rates with the first-line therapy matter, and we have one shot and we need to make that count. Combinatorial approaches with dose-adjusted R-DA-EPOCH have shown promising activity. However, we need to balance efficacy with toxicity. ZUMA-23, which is first-line CAR-T in high-risk large B-cell lymphoma patients, is eagerly awaited. I would like to thank the audience for patiently listening to this talk, and I hope I convinced you that there are options beyond dose-adjusted R-DA-EPOCH in 2022, though the data is early, but I think the future looks very bright. Thank you so much for your attention.
Thank you very much to the organizers for the invitation to speak at this meeting of controversies in lymphoma. And I think when we think of controversies in lymphoma, certainly CNS prophylaxis comes to mind, and my task is to discuss this for the next 20 minutes or so. These are my disclosures. So I'm going to begin with just a bit of historical context for how we kind of got to this point when we think about CNS prophylaxis. And I'm then going to try and answer the kind of key questions in this topic, which is who should potentially receive CNS prophylaxis, what should we give, when should we give it? But of course, the biggest question of all, and perhaps more relevant now in 2022, is should we be giving it at all? And I'll give some arguments for and against that. And we'll finish just by looking to future directions for the field, and also maybe a proposed approach for how we deal with this problem in light of current data. So it's very interesting going back to and look at some of the historical data. And if we even go back as far as the 1970s, this is a paper which describes cases of central nervous system relapse in non-Hodgkin lymphoma. And obviously our pathological classification has moved on somewhat since then, but assuming that some of these were probably DLBCL, the main theme in the papers at this time was that there was a recognition of the very poor prognosis of patients experiencing this event. And this paper from 1979 is very interesting, which discussed some of the ways that we could potentially reduce this risk for patients. And it's so interesting to see that some of the themes and thoughts back then are the same problems we're dealing with today. And I've just highlighted here the statement that if we were to give routine prophylaxis, it should be simple, relatively non-toxic, and not compromise systemic therapy. And of course, that's an issue that we continue to struggle with now. And also to highlight this in the same paper, where they discuss potentially giving prophylaxis to high-risk patients, they recognized, as you can see at the bottom, that they would still miss some CNS relapses occurring in other patients. And again, that's a problem we continue to deal with, which is the lack of sensitivity of our methods for identifying these high-risk patients. And of course, what we must remember throughout the discussion about this topic is what we're trying to prevent, which unfortunately is an outcome associated with very poor prognosis. And on the left here, you can see this large data set from Tarek El-Ghalali and colleagues of nearly 300 patients with secondary CNS lymphoma, showing a very poor median overall survival of less than 4 months. And on the right, we now have data from the hugely impressive Marietta study, which is a prospective trial of secondary CNS lymphoma. However, within this group, as you can see in the Kaplan-Meier curve, patients who were enrolled who had experienced secondary CNS lymphoma after previous R-CHOP therapy continued to do extremely poorly with a 2-year PFS of only 28%. And really, this is the group that we are targeting when we are considering giving CNS prophylaxis. So I think this needs to be remembered throughout our discussions. And here I've summarized the kind of 3 different guidelines from Britain, America, and Europe. And I think what this really reflects is the lack of good quality data which we have to guide our decisions here, because there is really quite a lot of variation in what's recommended worldwide. And I'll just highlight some of the similarities and differences here. So a high CNS IPI score is now recommended in the British and American guidelines for identifying high-risk patients, although the ESMO guideline still states high IPI, although I suspect now it would be CNS IPI. And high-risk extranodal site involvement is a common theme, although there are subtle differences between which sites are included between the guidelines, there are certainly common sites such as testicular, renal, adrenal, and breast, which are considered high risk. And what you can see highlighted here is that high-dose methotrexate is now generally recommended, excuse me, for CNS prophylaxis, although the ESMO guideline certainly is a little bit more cautious in its recommendation. And interestingly, intrathecal prophylaxis is not recommended by either the British or ESMO guideline, but the NCCN guideline continues to suggest that it could still be offered. And going back to the CNS IPI, this has undoubtedly been a step forward in how we try to risk stratify patients for this problem. And just to briefly summarize, as we all know now, I'm sure that the score is made up of the standard IPI plus an additional point for renal or adrenal involvement, with a clear increased risk with each additional point. And it results in a high-risk group with a score of 4 or more who have a CNS relapse risk of 10%. But it is worth noting that this is still quite a heterogeneous group, with patients with a score of 5 or 6 in particular having really very high CNS relapse risk, as you can see. And the other important point is that if we were to restrict our prophylaxis to patients who only have a high score of 4 or more, we will miss a significant proportion of CNS relapses which occur in the lower intermediate groups. So although the CNS IPI is very helpful, it does lack the positive predictive value that we really need to identify all these patients. And finally, it's worth remembering that patients who have a high CNS IPI inherently have a high risk of systemic treatment failure. And a standard IPI of 4, we know, confers a PFS of around 50% at best. So that's an important theme, which is that systemic failure is always a greater risk for these patients than CNS relapse. And in addition to the CNS IPI, specific extranodal sites we now would consider to be independently high risk. And this would include renal, adrenal, which came out in the CNS IPI independently, and I think that's well accepted now. Breast involvement is maybe slightly more controversial, potentially due to underrepresentation in historically in kind of prospective trials. But certainly there are several retrospective series reporting very high rates of CNS relapse in this group. And the total number of extranodal sites has now been demonstrated to be clearly prognostic from this really nice work from Tarek El-Ghawali and colleagues, showing that a group with 3 or more extranodal sites had a 3-year CNS relapse risk of 15%, and it increased significantly with each additional site. And I think this could be used independently as a means of identifying high-risk patients. And on continuing on extranodal sites, I think testicular DLBCL is perhaps worthy of separate consideration. And it probably is the extranodal site historically associated with certainly with the strongest evidence to suggest very high rates of CNS relapse in this group. And this is actually the only area in this whole topic where we do have some prospective trial data to guide management. And this has been from the ILSG group. And this is the ILSG 30 study presented last year. As you can see, it involved the use of R-CHOP with incorporation of intrathecals, followed by intermediate dose of methotrexate at 1.5 grams per meter squared and radiotherapy to the contralateral testicle. And very impressively, no CNS relapses were seen when this data was reported. However, we really do need to be mindful of the small numbers here, the fact that this was a trial population, and it's debatable whether the dose of methotrexate was sufficient. Historically, we've always considered a dose of 3 grams per meter squared or more to be required, and this used a lower dose. And of course, we don't know exactly what was having most impact. Was it the intrathecals? Was it the methotrexate? Or was it the radiotherapy? But the group must be commended for carrying out a prospective trial in this difficult area. And we now can use some biological factors to potentially guide risk stratification. And double hit lymphoma, as it was previously known, certainly historically has been associated with high risk of CNS relapse, although perhaps more recent data suggests this is a heterogeneous group, and for some patients, it's more the high-risk clinical features they present with rather than the disease biology per se that confers risk. And ABC subtype, when determined by gene expression profiling, does appear to be prognostic, with data from the Goya study identifying a high-risk group using gene expression profiling in combination with the CNS IPI, although gene expression profiling clearly hasn't taken off and is not used in routine clinical practice, so it's difficult to know how much we can use this on a day-to-day basis. And finally, potentially the area of most promise is is using our new molecular taxonomy of DLBCL, which has resulted in identification of the MCD or C5 cluster, depending on which classification you use. And this is a group of patients who have a high frequency of MYD88 and CD79B mutations, almost always ABC subtype, and they're found recurrently in primarily extranodal lymphomas such as CNS and testicular. And there has been a publication, a series where they've identified a series of patients with CNS relapse, where these clusters and mutations were found in nearly half of CNS relapse cases. So this may well be an area which can improve our means to identify high-risk patients if this technology can be incorporated into routine practice. So moving on now to what we should use, and I've got one slide on intrathecal therapy, which my own feeling is that we now have cumulative evidence to say that really it does not appear to benefit or reduce rates of CNS relapse. And this table, without going through it in detail, really just identifies a series of publications over the last 10 years, none of which have managed to demonstrate any potential benefit of intrathecal therapy. And of course, this is backed up by the rationale that the majority of CNS relapses in the rituximab era are parenchymal and would not be penetrated by intrathecal therapy. And Toby Eyre and colleagues carried out a large systematic review of over 7,000 patients published a couple of years ago, which showed no benefit of standalone IT prophylaxis. And I think it would now be fairly well accepted that IT therapy has a very limited role, with the possible exception of testicular DLBCL, which we will come back to. So the field has very much moved towards the use of high-dose methotrexate over the last 10 years. And this is despite a lack of prospective data demonstrating its efficacy, and importantly, how we should actually deliver it with our R-CHOP therapy. There's rationale to deliver it early, given the median time to CNS relapse. So the two approaches used have been, one would be to intercalate the high-dose methotrexate between R-CHOP cycles, meaning you get early CNS prophylaxis delivery, but of course the concern would be the toxicity and potentially compromising your systemic therapy. And the alternative approach used by some is to deliver at the end of treatment, and accepting a risk that this may not prevent some early CNS events, but of course it will not interrupt R-CHOP therapy. And there have been a series of publications over the years supporting methotrexate use in this way. So a couple of studies supporting intercalated methotrexate, initially one published about 12 years ago now, a single center study demonstrating low rates of CNS relapse. And indeed a prospective phase 2 trial from the Nordic group, which really did not just use early high-dose methotrexate, it involved very dose-dense immunochemotherapy and CNS penetrating agents. And I think this is a very intensive regimen. It's hard to know whether this really could be incorporated routinely. And similarly, two studies supporting end-of-treatment methotrexate use, one from Andre Ferreri and colleagues, and one from Chan Che, again suggesting a potential benefit of high-dose methotrexate at the end of treatment, but the common theme here clearly is the small numbers involved and the lack of statistical power to really prove benefit. And we've carried out work in this area, really trying to determine whether there was any strong evidence to support giving early methotrexate or not. And we initially carried out a UK study, which the primary finding was that there were certainly increased R-CHOP delays when you use intercalated methotrexate. So we then went on to expand this internationally to 47 centers worldwide, looking at DLBCL patients who'd had R-CHOP with high-dose methotrexate, either intercalated or at end of treatment. And our primary endpoint for this large study was really to determine was there any difference in 3-year cumulative incidence of CNS relapse. And we presented this at ASH last year and published earlier this year. Our baseline characteristics are shown. So as you can see, we had over 1,300 patients with roughly equal numbers in the two groups. And the two groups were pretty well balanced. And without going through in detail, just to highlight at the bottom, the CNS IPI, there was a slight trend towards higher CNS IPI overall in the intercalated group. However, when you look at the numbers who had high CNS IPI of 4 to 6, really it was very similar between groups. So these groups were relatively well balanced. And here's our main finding, which was that essentially there was no difference in 3-year CNS relapse rate between intercalated and end of treatment delivery of methotrexate. And on the left, this is all patients. And on the right is a landmark analysis to mitigate for immortality bias due to the retrospective nature of the data. And this lack of difference was included in multivariable analyses, and also when we restricted our analyses to CNS relapses occurring isolated from systemic relapse. Another very important finding was that, again, we clearly demonstrated an increased risk of delay with intercalated methotrexate, with 1 in 5 intercalated methotrexate treatments resulting in an R-CHOP, or certainly being associated with an R-CHOP delay. We did demonstrate that this could potentially be reduced by delivering the methotrexate earlier in the R-CHOP cycle. But these delays really do appear to be important when we demonstrated that any patient having a delay, they certainly had a worse PFS to those who did not. And I think this supports what we've always thought, which is the importance of maintaining dose density of R-CHOP. And I think this is a very important consideration. And our final very interesting finding really was looking at our high-risk subset of patients, and we really could not find any benefit of intercalated methotrexate in any of these high-risk groups. And indeed, when we looked at our high CNS IPI group of 4 to 6, the overall rate of CNS relapse was 9.1%. And that's very similar to the CNS relapse rate seen in the original CNS IPI study, where very little high-dose methotrexate was used. And of course, this raises the big question, is it really doing anything at all? And actually, over the last few years now, multiple publications have been produced really questioning the role of high-dose methotrexate, and this summary really showing that none of them have managed to show a difference other than this study from Ong and colleagues, potentially showing a reduction in isolated CNS relapses, but really with very small numbers. But the largest study to date addressing this question was also presented at ASH last year from Kat Lewis and colleagues, and they carried out a really impressive large international analysis of high-risk patients as per the criteria listed on the slide, patients receiving curative intent therapy with or without high-dose methotrexate. They had a pre-planned power calculation, which determined they would need 650 high-dose methotrexate treated patients to have sufficient power to detect a reduction in CNS relapse rate. They managed to collect data from well over 2,000 patients. However, it is notable that the high-dose methotrexate group had just under 400, so certainly on the most recently presented data did not meet the pre-planned power calculation. And also just worth pointing out here that there did appear to be some difference in the risk between groups, with the increased number of patients with extranodal sites in the high-dose methotrexate arm and more patients with very high-risk sites such as renal, adrenal, and testicular. But again, their findings here are summarized, which was that there was no benefit, apparent benefit to high-dose methotrexate, and that included in all patients and also in a similar landmark analysis to mitigate for immortality bias. They also carried out subgroup analyses looking at all these various kind of potentially ultra high-risk groups, and they found no signal towards benefit of high-dose methotrexate in any of these subgroups. Although, as you can see in this table in the high-dose methotrexate column, really we must be very mindful of the very small numbers involved when we drill down on these ultra high-risk subgroups. So their summary was that high-dose methotrexate was not associated with a reduction in CNS relapse overall, or indeed in any of the high-risk subgroups we showed. And the overall incidence of CNS relapse, again, was 9%, similar to our study, and again, similar to historical data, and that's despite a significant proportion receiving high-dose methotrexate. And of course, we have to be mindful of some caveats in terms of underpowered treatment arms, imbalances in baseline characteristics, and the small numbers in the ultra high-risk groups. But I think this study is hugely impressive and probably the best data set we will have, and we await final publication with interest. So now really to look at where the field should move to in the future. And I think ctDNA is a very exciting area in lymphoma management in general, but I think in this particular topic, I think there's a great promise. And there's been a couple of publications, the first of which was from Adam Malczewski and colleagues last year, where they looked at used an NGS MRD assay to detect clonotypic CF cell-free DNA in the CSF. And in a series of patients with known CNS involvement, they were able to detect ctDNA and CSF of all these patients, even if they only had parenchymal disease. And they then looked at a series of patients with high CNS risk, and they found that positive ctDNA in the CSF was clearly predictive of future CNS relapse, with a risk of 29% in positive cases and no relapses occurring in those with negative ctDNA in the CSF. And Sabea Babio and colleagues also published this series of patients of a mixture of both primary CNS lymphoma and detect CSF ctDNA and baseline in all patients with restricted CNS lymphoma, even if it was only parenchymal. And they found positive CSF ctDNA in one patient with systemic lymphoma who went on to have a CNS relapse, and one patient with primary CNS lymphoma who appeared to be in remission, but did then go on to relapse. So I think this technology surely needs to be incorporated into any future studies looking at this area, and I think is really exciting. So to summarize, what could you really consider the arguments be for and against CNS prophylaxis in 2022? Arguments for would be that, as we said, these outcomes for secondary CNS lymphoma are very poor. There is certainly rationale for high-dose methotrexate, and we know it's effective in other CNS lymphomas. And in all, we must be mindful of the potential bias in retrospective studies suggesting there is no benefit. And indeed, we do actually have prospective data in testicular DLBCL suggestive of a possible benefit of high-dose methotrexate. And what we've also now been able to demonstrate is that if you deliver it at the end of treatment, it does not interrupt your systemic therapy and appears to be, and can be well tolerated in selected patients. Arguments against, I think firstly, many would argue that CNS relapse is occurring probably due to occult disease at baseline, which we aren't able to detect with many of our methods that we use currently in clinical practice. And really what we need to be doing is improving our methods of detection of this, and ctDNA clearly is very exciting in this field. And of course, the big question will be then, what do you do? Do you treat patients differently if you do find this occult disease? Most CNS relapses occur with systemic relapse, and you would argue that that is more of a failure of systemic treatment than CNS prophylaxis. High-dose methotrexate is toxic, can be difficult to deliver, results in an inpatient stay, and that has financial implications as well. And of course, as we've discussed, there is now this cumulative body of evidence suggesting a lack of benefit. I think we probably do need to factor potential improved future treatment options for patients with secondary CNS lymphoma, such as CAR T cells, which is not currently available, but certainly has very exciting data. And that might well influence that risk balance discussion with patients at the outset. And I think the implications of our increased knowledge of the molecular classification of DLBCL certainly is where we should probably focus in terms of better risk stratification of patients, and also identifying targetable mutations that may help to overcome this increased risk. And finally, this would be my proposed approaches to CNS prophylaxis based on the current available evidence. But of course, this is very much subject to debate and is not backed up by really a good quality of evidence. But I think now there probably should be a greater emphasis on baseline screening. And obviously we can do that now with MRI and the analysis of CSF. But I think, as we've seen, CSF ctDNA, once that technology is available, will really be very important to try and incorporate. And then the big question will be, what do you do if you identify positive results at baseline? Then there would be an argument to considering more dose-intense CNS penetrating regimens as listed there. But my feeling is we should, at the very least, be reserving high-dose methotrexate, or certainly be more cautious in its use, and perhaps reserve for patients with so-called ultra-high risk characteristics. And pragmatically speaking, you could consider this to be high CNS IPI, 5 to 6, 3 or more extranodal sites, or these very high-risk extranodal sites. I think if you're going to use it, it should be delivered at the end of treatment after confirmation of remission. And there maybe is only a role for IT therapy in testicular DLBCL based on the prospective ILSG data. And I think going forward, clinical trial involvement, and particularly those trials incorporating novel agents such as BTK inhibitors, are going to be very interesting to see whether they impact on CNS relapse rates overall. I'd like to finish there and just finish by thanking all my colleagues across the world who contributed to our high-dose methotrexate study, the members of the project working group in this study, and also of the BSH guideline working group, and Dr. Babio and Lewis for the use of their data. Many thanks.
Well, thank you so much for all the speakers. Really fantastic frontline CNS lymphoma session. I must say all the 5 talks were truly outstanding. And we have had a lot of questions from the audience. So I'm gonna start with a question, and I guess it's a similar question, and the same question is directed to Dr. Sehn as well as to Dr. Dunleavy. And the question is, if you happen to know that your patient has either 17p deletion or TP53 alterations, does that really impact your choice for Dr. Sehn to pick the Pola-R-CHP based regimen or for Kieron dose-adjusted EPOCH?
Yeah, that's I might defer to Kieron and see his opinion on this, but I think that at the present time, the mutational analysis regarding P53 is not something that we routinely measure in the clinic. What we do recognize is that that there is high-grade biology that probably we are best to measure across a spectrum of genomic testing. And of course, we heard some of the data regarding high-grade biology and how it may influence future treatment. I think right now, the only thing we're doing in clinical practice really relates to FISH testing, as we heard, to identify the double hit cases. I know that, the recent concept of triple hit with the BCL6 has kind of been eliminated from the recent classification. So in my own clinic, we're really focusing on dual rearrangement of MYC and BCL2, and those are the only patients that we treat differently. I think in the future, we will move toward genomic platforms where we try and identify high-grade B-cell biology and then consider what might be optimal approaches, but we're not quite there yet.
I can just comment on that and add to Laurie's comments. I think that P53 is aberrant in a high proportion of aggressive B-cell lymphomas. In some studies, it's approximately 20%, and most of those are P53 mutant. In terms of high-grade B-cell lymphoma and outcome, it really hasn't been looked at, but it's associated with a worse outcome in diffuse large B-cell lymphoma. There is one molecular study that actually looked at a double hit signature with P53 aberrations and showed a particularly poor outcome. But at this point in time, in terms of selecting therapy, as Laurie said, it's not routinely done in all centers, but we do know that it's associated with a worse outcome, but I think it doesn't change therapy. But it's a very interesting question and should be studied more. The other thing I would say as well is that it sort of raises in my head anyway, is there underlying follicular lymphoma? I think a proportion of high-grade B-cell lymphomas are transformed lymphomas versus de novo high-grade B-cell lymphoma. And I think if P53 is aberrant, I think that you should consider looking for an underlying follicular lymphoma. And the prognosis is probably worse with these regimens if it's transformed versus de novo.
All right, thank you for those answers. The next question is directed to Dr. Sehn and also to Dr. Wilson, and that is there a role for polatuzumab in patients who have CNS disease, so secondary CNS involvement with lymphoma?
Yeah, so we don't have much data, but just based on the size of polatuzumab, we don't anticipate that it's going to have any significant role in crossing the blood-brain barrier and making impact. But, to my knowledge, there's no real data on it. But I don't think it's likely to be a useful drug.
Thank you.
Yeah, I would agree with that. I'm not aware of any data that it does cross the blood-brain barrier, but I think maybe part of the question is relating to the idea that if we improve systemic disease control, will that impact on CNS relapse rates? And I think that hopefully will, but trying to prove this in quite a small subset of patients at the very high risk is always going to be challenging. But I think improving systemic disease control undoubtedly could hopefully reduce CNS relapses.
Great, thanks.
So I think the next question is going to be for Dr. Epperla, and and I would also like Kieron to chip in. So the question is that in resource-poor countries, cell therapy in frontline, at least on trials, is difficult, and I'm sure they're alluding to probably the data that Naren showed. The question is, bispecifics might be more feasible in that setting. So the question is, how do you guys see the role of bispecifics specifically for the double-hit lymphomas in frontline settings? So Naren first, followed by Kieron. Naren, we can't hear you. Are you on mute?
Can you hear me?
Yes.
Can you hear me now?
Yes, we can. Thank you, Naren.
Sorry about that. So I think that's a very important question, right? So especially the health economics, as rightfully alluded to in this session, plays a very, very important role in choosing the regimens in the frontline setting. Completely agree with the notion that moving CAR-Ts into the frontline setting, although will help with these high-risk behaviors, but we also need to balance off, especially in countries where cost will come into play. I think personally, the data with combining bispecifics with multi-agent chemotherapy appears promising, but I'm still awaiting the data in this double-hit lymphomas to see truly how much of an impact it will place, right? So essentially, as Dr. Nilanjan presented, yes, the response rates are fantastic. However, how did it do in the double-hit lymphomas specifically? And so that is what I wanted to know. That's what I want to learn going forward. But at this stage, I think outside of clinical trials and bispecifics, those are just R-DA-EPOCH still remains a good option in those settings. But definitely a bispecific combo with a multi-agent chemotherapy, if it shows effective, if it shows effectiveness in the frontline setting, I would opt that over a CAR-T-based regimen.
All right, thank you. I think we are running short of time, but we may be able to get another one more question in. And the question is the CNS prophylaxis in HIV patients. So Dr. Wilson, if you can take that one, please.
Yeah, well, historically, patients with diffuse large B-cell lymphoma and HIV have had high rates of CNS relapse, but I think probably that relates to them often presenting with high-risk features, high IPI, extranodal sites, etc. And arguably, it's really those clinical high-risk features that give the high risk rather than the HIV status itself. So we certainly have treated these patients with the same criteria that we do for anybody else with DLBCL in terms of our when we give CNS prophylaxis and whether high-dose methotrexate works specifically in this group or not. I think we just don't have the data to say, but I think whatever criteria you're using overall for DLBCL, I think should be applied similarly to this group.
So just a quick follow-up on that. Many patients with HIV will get R-EPOCH. Trying to, if they have CNS involvement along with that, that's a huge challenge to incorporate high-dose methotrexate along with R-EPOCH. We've done that with our CHOP, as Mr. CHOP regimen is sometimes known, but with R-EPOCH, it's more challenging. So do you then just follow up with high-dose methotrexate at the end after you finish the R-EPOCH for prophylaxis, or what do you do for patients who already have CNS involvement and systemic and need to use something like EPOCH? What's your approach?
Yeah, I think as you say, in trying to incorporate high-dose methotrexate intercalate